Shujaa Day celebrations, but tonight it's all about healthcare in the country. That is one of the greatest milestones that has been marked today. The president signed 4 bills into act, essentially becoming law. The first one was the Social Health Insurance Act. The next one is the Primary Healthcare Act, Facilities Improvement Financing Act, and the Digital Health Act. We'll find out from the Cabinet Secretary who is steering this whole transition on what each and every act means for the common mwananchi. We'd like you to send in your questions as well at Trevor Mbiji at Sam Gituku. Use the hashtag tonight. Let me introduce my guest from the host governor, His Excellency Dr. Eric Mutai, Governor for Kericho. Thank you so much for making time this evening. And Dr. Suzanne Nakumicha, CS Health. Thank you very much for making time. CS, let's get straight into it. So 4 bills were signed into acts today by the president. Let's start from the Social Health Insurance Act. What will be the impact of the Social Health Insurance Act to healthcare provision in the country going forward?
Thank you, Trevor, and thank you, Governor Mutai, for hosting me since when I arrived on Sunday up to now. Today is a momentous day for the Ministry of Health and for me as a person equally. The President has assented to law 4 bills. And you have begun with the Social Health Act, which I think is the most one that has elicited a lot of discussions. And why has that bill elicited a lot of discussion? It's because it is the one that is responsible for financing of healthcare. You know, where money is, people really want to discuss things to do with money, and I want to believe that's the reason why that particular act has elicited a lot of discussion. His Excellency the President committed that we are going to have universal health coverage. And basically what that means is that a Kenyan can be able to access quality health care as and when they need it and where they need it without suffering any financial loss. And that is why now we have the Social Health Act that indicates how are we going to ensure that we finance the healthcare. So what that act has done is that it has brought into place 4 levels of financing. One is a primary healthcare financing, where all Kenyans will access services at the lower level. That is level 1, level 2, that is publicly financed. That when you go to access a service, you're not going to be asked to make any payment. Then level 2 is the social health insurance, where we expect that then we are going to register Kenyans into a health insurance. A premium is going to be determined of how much one needs to pay into that.
So it's not been determined yet. Let's start from there.
It has not been determined yet. Okay. We have just, the bills have now been signed into law, and for you to actualize or to operationalize a law, you need regulations. It's within the regulations that we are going to define the how we are going to implement the act. Okay. And the third fund that has been established then is the Emergency, Chronic and Critical Illness Fund that will take care of Kenyans in case of an accident. Kenyans know that at the moment, if an accident happened and you are picked from a scene and taken to a health facility, many people or many facilities will be hesitant to touch the person who has been involved in an accident, being that if it's a private, they are looking at profits, they are looking at revenues. How will they make their revenues? And since they don't know who is going to pay, then they don't touch you. And at times, it is just what will make a difference between life and death, that few moments that you arrive there. So what this fund does is ensures that once you arrive at a health facility, be it a public facility, a faith-based facility, or a private facility, they will give you assistance, or they will give you the service that you so much need. Trevor, we are suffering as a country at the moment. The NCDs are on the rise. Many people have non-communicable diseases are going up, things like diabetes, things like hypertension. So we have to focus into this. And that fund that we are creating then will take care of those on chronic illnesses. You know, most of them, once the medicine has been prescribed, then they're expected to be on that prescription for a long time. So they are going then to be benefiting from this fund. And the other one is critical illnesses. One of them, you know, is cancer. In Kenya right now, when a family member is diagnosed with cancer, they will form WhatsApp groups to start collecting money. Before you know it, they'll be selling property to collect money to take care of that patient. So then we have thought the best way is to have a fund where once then you are determined to have critical illness, that fund kicks in to take care of your illnesses. That is the essence of the Social Health Act, and it is going to repeal the National Hospital Insurance Fund. So we are no longer going to have that. We are going to have the Social Health Authority that then has the mandate to ensure that it takes care of financing of healthcare within the country.
So this transition period, and there's a lot of questions on this, and I know you mentioned that the regulation has not been done yet. So how long is the transition period?
One, we have the immediate, which I can call an immediate transition from NHIF to Social Health Authority. We have planned for a year.
Okay.
That within this 1 year, then we shall be seeing how best do we transition the operations, how best do we move whatever was in NHIF into Social Health Authority.
Okay.
However, immediately after we have finalized on the regulations, and remember regulations have to go through the constitutional process as well. We must have public participation on that. We must take them through all stakeholder involvement. Once the regulations have been passed and we have gazetted the regulations, then we begin the process. One is registration, that we have to list members into, we have to enroll members or register them into the social health insurance. After we have begun with registration, we go into payments, because it's one thing to register, one thing to pay up, you know, and that is one of the diseases that is killing NHIF now. We have so many people registered, but once you go to the paying up point, they don't pay up. They opt in, but do not pay up for the premiums. So we shall have that period. Our expectation is that within the year, after we have moved from NHIF to Social Health Authority, within another 6 to 9 months, we should now be able to begin and say firmly that now we are on Social Health Authority.
So we don't have a figure yet, because there were figures that were bundled around in terms of 2.75% of gross salary deductions, minimum of 300 shillings.
Let me make a clarity on that. Before we finalize on the Social Health Authority, we thought, how best do we ensure that Kenyans still have access to services? So our immediate thinking was that we do an amendment to NHIF. Therefore, we did regulations for amendment. And that is where we came up with that figure. So now that we have gone into Social Health Authority, we shall be working on the regulations. Should we still say that 2.75% is the figure, then we shall inform Kenyans and it will form part of the regulations. Should we determine that it ought to be different, then we will determine at that time into the regulation. However, I know myself and even the President has already talked about it. The most important thing is we must have a standard of payment. Previously, the low-income earners have been paying as high as 14% of their income to NHIF. The high-income earners have been less than 2% for some of them. So now we want to create a standard that if it is a percentage, it's a percentage of your income, regardless of what your income is.
So there will be no top capping. It's a percentage of your income, full stop. If it's 2.75%, it depends on how much you earn.
Remember, I have said once we develop the regulations, we will take them through the process, the constitutional process of forming regulations. We will draft something, put it out into the public for public participation. We will receive feedback. It is my prayer, if we are able to say 2.75% of income regardless, the better, because we'll be able to collect more in terms of being able to finance healthcare. But depending on what the public says, if they say, no, this thing is better off having a cap in terms of a limit, we'll go by what the stakeholders will have to say. But we have worked out numbers, and I think we shall be putting that to the public in terms of public participation. We'll take in their feedback.
Yeah, I'm insisting on this numbers thing, because when we were with you in the big conversation at the Citizen TV, you mentioned that SHIF is looking to raise 144 billion shillings, which NHIF was raising only 44 billion shillings. So do we know how much Kenyans are spending on healthcare annually, and how much of that is out of pocket?
Yes, we know. The total health expenditure of Kenya is 550 billion.
550 billion?
550 billion.
Okay.
Out of pocket expenditure is about 150 billion.
Okay.
So the way we have planned ourselves is that the primary level, our projection is that we should be able to spend about 70 to 77 to 80 billion per year. While the social health insurance, where many Kenyans are paying out of pocket, then we should be able to spend that 140 to 145 to 150 billion. Then now we shall have the emergency fund. We are capping at about 50 billion maximum. Okay.
Yeah. Let me bring in Governor Mutai on this. And Governor, are you ready as counties to implement UHC?
Yeah, thanks so much, Trevor. And first of all, I wish to welcome the community health volunteers that are here with us, the CHFs, and also everybody from Mashujaa tomorrow. But I must confirm, first of all, that we have a very engaging Cabinet Secretary of Health. And as COG, we've been able to have a lot of conversation with her. Nothing comes to us and pushed to us through the throat. And I confirm that in the past we have very arrogant ministers who didn't care to listen to what COG was saying. But in this William Ruto administration, we have level-headed people that we can have a discussion. As counties, we have looked into our margins and what we can do. And among the things that we have looked into is our capacity with the facility improvement funds and how we can tame wastage and corruption within our health facilities. A good example is Lake Region County when I took over. One of the things I realized that was that we were not very good in the past in terms of streamlining the money that we collect from the patients, which translates to sometimes, in every side you cannot miss one or two, funny people getting into their pockets. So one is that as county governments, I want to commit that we are ready, first of all, in fact, in matters community health workers that we are doing the business of tomorrow, we are ready to meet the 50% and match what the national government is providing us. The reason why we are doing this is that we realized that for a decade, the community health workers, as they were called at that time, were doing great jobs, but they were informal and they were not recognized in the jobs that they were doing. They saved so many women who would have otherwise given birth in the bush and die in the bush with a baby. And we imagine that now the William Ruto administration is trying hard to formalize these structures and make it work so that we are able to save lives within the villages. As COG, we are committed to meet our beats from what the national government is giving us so that we are able to give the stipends to them.
Okay.
Yep.
All right. And CS, let me come back to you on this, and I'll open the floor for questions. Let's talk about now the Primary Healthcare Act. How will that change the game when it comes to PHC?
Thank you, Trevor. The Primary Healthcare Act, its intention is to shift focus from the curative to preventive and promotive health. Many people have said it, I will repeat again. It is a smart investment when you do it in primary healthcare, because for every shilling that you spend in primary healthcare, you are saving about 9 shillings in curative services. So that act is to ensure that we are shifting. But the other thing, besides shifting and providing service at the primary level, that is the level 1, level 2, level up to level 3, besides shifting focus to that, the other thing is ensuring that we are networking facilities, that we know what is the capacity of each facility in terms of service provision. As it stands now, and Governor here will agree with me, there are facilities that we'll go to that is said to be a level 4 facility. But if you look at the kind of services that they are offering, they are even a level 2 or level 3. So what the other thing that this primary care network is doing is that we are looking at we have assessed the level of service of each facility. So we are putting them in a network so that a Kenyan knows that once my community health promoter, for example, has referred me, has seen that I need attention, they have referred me to a facility. This is a facility that I'm tied to. You do not waste time trying to think where should you go, because one, you have been directed by the community health promoter. Then once they arrive at the facility, should this facility not be in a position to take care of the patient and they have to refer to the next level of service, then they know what facility they are going to. So that a patient is not hanging around, no time is being wasted in terms of identifying what facility this patient should end to. And what is very critical, Trevor, is that in this primary care network, it does not matter whether it's a public facility, is a faith-based facility, or a private facility. They have all been mapped into a network. The essence is that they should be able to provide service to Kenyans. And what government is going to do is to be a strategic purchaser of service. Okay. Yes, so that is what the Primary Care Act is all about, and also just to define roles. The way Governor has said, you know, this is a shared responsibility. So there's a definition of clear roles and clear boundaries of who ought to do what within the primary health care.
And that is where the issue is, Governor. But I have to take a quick break here. When you come back, we still have 2 more to go through, and then I'll open the floor for questions in terms of all of them. But keep it right here on Citizen TV, live from the Sunshine or Sunrise Hotel, right here in Kericho. See you in just a bit.